you have some time, I would also discuss with you some urodynamic findings I have observed and that are repeatedly cause discussions in conferences. It's regarding Detrusor overactivity. So often we see Detrusor overactivity as a sharp increase, like you presented in your trace of the MS patient. But sometimes you see Detrusor overactivity. It is not completely sharply increasing. So I have here an example of a 69-year-old patient with Parkinson's disease since 2013, and he is under therapy with trospium chloride. And here you see that he has phasic terminal detrusor, he has a phasic detrusor overactivity, and it's a nice sharp increase, and he has leakage combined with that. But sometimes, and that's my second example, you see here a Detrusor overactivity in a 46-year-old female patient with MS. She has a rather slow increasing Detrusor overactivity that some colleagues would rather interpret as lack of compliance. And certainly it could be a combination of both. But I always understood that there is no clear definition on how Detrusor overactivity should look like. So it could have different shapes. Even it could increase and stay on a certain level, and then either you leak and then the detrusor pressure is decreasing, or it stays on a high level, which is even more dangerous. How is your experience with that interpretation of detrusor overactivity?
Yeah, so I mean, I find detrusor overactivity is still a little bit of an art as well as a science. And as you know, there's no sort of minimum cutoff for pressure or anything in terms of defining detrusor overactivity or shape, as you said. So usually when I'm characterizing detrusor overactivity and teaching the residents to describe it, I want to know the volume of first onset, the shape, associated events like incontinence, and the peak pressures. And I want to know how long that's sustained for. And sometimes it can be deceiving depending on how long your urodynamic study is. Sometimes the detrusor overactivity is compressed. If you've got a 20-minute study, it may look like a fairly short, sharp peak, but it may actually have lasted for a minute or two. So you always have to look at the time scale there to sort of get a sense of how long it's sustained for. For me, my challenge is, it definitely impacts management if someone has poor compliance or if someone has detrusor overactivity, especially in neurogenic patients, obviously, where we know that poor compliance is a potentially common and serious complication of neurologic diseases. So for me, if the detrusor overactivity is isolated, so there's a rise and a fall, then that's a pretty clear episode of neurogenic detrusor overactivity. If it's sustained, as you said, and sort of a slow increase over time, then you got to sort of be a bit of a detective and try to look for some other clues to tell if it's poor compliance or not. So for me, I'll sometimes look for, the morphology of the bladder if I'm doing video urodynamics. I'll look at the thickness of the bladder wall if I have access to some ultrasound imaging or CT imaging of the bladder. I'll look at the capacity over which it's happening. So, if it's happening right away at filling and sustained throughout filling, I'm a little bit more likely to think that's poor compliance as opposed to detrusor overactivity. And then if the patient sort of has a sudden sensation with it, like urgency, or suddenly begins to leak with it, again, I'll lean a little bit more towards neurogenic detrusor overactivity as opposed to poor compliance. So I agree with you. It's a really difficult thing to diagnose in some people. Some people it's obvious, but for some people you really need to do some detective work. And ultimately, if someone has poor compliance, there aren't a lot of good treatments that are going to fix that. Then you're really looking at bladder augmentation as the treatment of choice for a bladder preservation approach. If they have neurogenic detrusor overactivity, then you've got lots of options there, right? You've got medical therapy, you've got onabotulinum toxin, you've got sacral neuromodulation potentially. So you've got a percutaneous tibial nerve neuromodulation. So you've got lots of different options there that you can try.
And would you, if you have a patient where you have more the impression, ooh, that's really poor compliance directly from the beginning, it's like a linear a trace, would you still try conservative treatment? Would you still say, give it a try of Botox injection, or would you directly go to surgery?
Yeah, so I mean, that's a good question. And I mean, there's been some papers published showing that perhaps in some cases compliance does improve with intravesical Botox treatment in the neurogenic population. I mean, I think in a lot of those people, probably it's like we talked about before, there's two problems. There's neurogenic detrusor overactivity and poor compliance. And the Botox improves that sort of hidden neurogenic detrusor overactivity and lets them fill to a greater volume at a slightly lower pressure. So my issue always is a trial of intravesical Botox, you really don't lose a lot by trying that. And the morbidity difference between intravesical Botox and a bladder augmentation is night and day, right? That's a pretty big difference in terms of how the patient recovers from that. So from my point of view, I would talk with the patient, and it depends a little bit on their goals. If they've tried some things and they're fed up, or if they have hydronephrosis and renal dysfunction, I might just go straight to bladder augmentation. If they're kind of more of an asymptomatic poor compliance, their capacity still, preserved somewhat. They still can fit in 200, 250 cc's in their bladder before the pressures get too high. Then I might trial an episode of a treatment of Botox. But this would definitely be someone I'd want to repeat urodynamics on 6 to 8 weeks after intravesical Botox to really see if I've made a difference to the urodynamic numbers.
Yeah. Okay. Here in that case, I present is that we in the ice water test, you sometimes can see that there is a steeper increase in the detrusor overactivity, although in the physiological body warm cystometries you don't see it. So could that be an option to differentiate between compliance and detrusor overactivity, or do you think it's not a good tool?
Yeah, so quite honestly, I don't tend to use ice water provocation tests too much during urodynamics. I think it's an option out there you could use, but I would struggle a little bit, I guess, to interpret that in the tough cases still. I think it would still kind of be tough to tell if that's you're proving that you're adding neurogenic detrusor overactivity with the addition of ice water, but I'm still not sure in the physiologic filling setting, is that then relevant? So is that neurogenic detrusor overactivity playing a relevant role, or is it not happening until 300 cc's of filling, at which point the bladder compliance has already made the patient leak? So I think it's a tool you could use. It's not something I tend to rely on very much in diagnosing my patients with neurologic diseases.
Okay. And now I present the trace following treatment with the oxybutynin dermal patch. And in the second, I see a much lesser increase in the detrusor overactivity in this 40-year-old MS patient. Would you say this is a good treatment effect, and if would that be an evidence that it was detrusor overactivity she had before and not a compliance problem? Also considering the amount of filling, which you cannot fully see, but which is more than 500 mLs.
Yeah, so I mean, from looking at this tracing here, the amplitude of the neurogenic detrusor overactivity is quite low at this point. And for me, I would treat this patient more based on symptoms rather than the urodynamic tracing. So I think you have evidence of neurogenic detrusor overactivity there, so you have a diagnosis, a urodynamic diagnosis. If she's having breakthrough urgency and urgent incontinence with the oxybutynin dermal patch, then I'd look at whether there's any conservative measures such as voiding more frequently so she's not getting to that higher volume, and see if that helps. And if that doesn't help, then looking at combination therapy with a beta-3 agonist, or if she's really bothered by her symptoms, looking at whether she wants to escalate therapy to something a bit more invasive, such as intravesical Botox treatments.
Okay, I absolutely agree.